Okay, so this is a talk on co-occurring substance use disorders and mental illness. It is an introductory talk that Dr. Bott put it together, and I've tweaked a little bit, but want to give him credit for the majority of these slides. We have no disclosures. So the objectives are to be able to appreciate how to differentiate between substance-induced and independent psychiatric illnesses, to identify the comorbidity between substance use disorder and various psychiatric illnesses, and to construct a treatment approach for patients who have both substance use disorder and psychiatric illness. So a brief review of the epidemiology. This is the latest survey data from 2022. And what you can see here in these two pieces on the left, we're looking at the distribution of adults who had substance use disorder alone in blue, the adults who had any mental illness, and then the overlap here of substance use disorder and any mental illness being at approximately 20.5 million people. Again, as with any of these surveys, this is all going to be quite probably grossly underestimated from the actual numbers. On the right, you'll see adults who had either substance use disorder or severe mental illness. And the overlap there coming to about 7.5 million people with both. So we know that substance use disorder alone increases the odds ratio for an axis 1 diagnosis, going back to our axes. I haven't seen those terms, I guess, in a little while. And also that an axis 1 diagnosis increases that odds ratio for having a substance use disorder. Also, having one substance use disorder increases the risk of having an additional substance use disorder, which is, again, brings up the importance of screening everybody for additional disease. So what we know about substance use disorder and serious mental illness is that people with substance use disorder alone showed 4.5 times greater risk approximately to suffer comorbid psychiatric conditions. And that people with psychiatric disorders had 4.5 times greater risk to have a substance use disorder. And of those, schizophrenia and affective anxiety disorders were among the most prevalent. This article from 2016 looked at prevalence of any lifetime substance use disorder in co-occurring psychiatric conditions and of 460,000. And you can see here at the top of the list at 37% was schizophrenia with the highest risk of having a substance use disorder. And in every psychiatric category down to OCD, alcohol use disorder was the most dominating type of substance use disorder. Also, the people who experienced these were more often men, had fewer years of formal education, more often received disability pension, and died due to unnatural causes, so accidental death. Here are some of the consequences that we know can be associated with these concurrent disorders. We see higher rates of psychiatric hospitalizations, increased number of psychiatric relapses and suicide attempts, and then spanning down violent behavior, imprisonment, homelessness, etc. So what about the assessment? We're going to talk about assessment of the intoxicated patient. This was mainly set up for the outpatient setting, but I think could also translate to inpatient as well. Certainly we want to be screening for suicidality, homicidality, reviewing their overall medical stability, first, of course, with their vitals, and attending to any emergent issues, and immediate withdrawal management, especially that could be potentially life-threatening. We wouldn't do a probing psychiatric evaluation, certainly in an intoxicated patient for obvious reasons, and we just need to try to gather as much information that could be helpful in the initial management. And certainly if there are relatives or a supportive person there who may also give information that's helpful, we can gather that with permission as well. And then we want to wait until their acute intoxication state has passed before gathering deeper information. So how do we distinguish between independent versus a substance-induced psychiatric disorder? Substance-induced, again, are going to be related to the use of the substance and usually resolve with sustaining abstinence from the substance. Not always, in some cases. One example certainly that comes up not infrequently is methamphetamine. We tend to see, certainly in the acute intoxication stage, perhaps more psychosis, and then that may go away in the days and weeks to follow, but we do see some cases of sustained psychiatric comorbidity related to use despite abstinence, but most of the time they typically will resolve. Versus an independent psychiatric disorder that's going to be present throughout times of abstinence as well, and that the symptoms are going to come and go not related to the use of the psychoactive substance. But importantly, there's not a specific time period. I know sometimes we were maybe taught wait a month and then see if the symptoms are present, but there's not a defined time period that's used to differentiate these disorders. But there certainly can be a spectrum of time that it takes. So again, substance-induced disorders, they only occur when someone is using the substance or in the aftermath, however long that may take. Symptoms related are to intoxication state or the withdrawal state or other aspects of active use. And we also tend to see that the onset or offset of symptoms is going to be preceded by increases or decreases in the substance use. So there is some pattern related to use. So the goals here is going to try to sustain abstinence and then be able to reevaluate for the co-occurring psychiatric condition. Versus independent disorders where they're not occurring when someone's not using, they are occurring, or they, with steady use, they don't change based on the time or amount or type of substance, that those symptoms are still there. Also, family history can be very helpful in pointing to an independent disorder. If it's present in a first-degree relative, you may not get that information again the first visit, but you may, or after meeting with the patient over time, that can help clarify. And so the goal is going to be treating the psychiatric symptoms. You'll see in a little bit, we want to, it's a cessation of use. We want to do that concurrently too, and wouldn't want to withhold treatment if someone's continuing to use. But when it becomes clearer what the diagnosis is, perhaps when they're not using, we may be able to more effectively treat. So the pearls, a couple pearls, again, family history can be important. Initial symptom onset, if you can gather that, can be very important as well, because certainly if someone has a clear history of psychiatric illness prior to any substance use initiation, that can point you to an independent illness. Many of our folks, may have started in adolescence, and so that can be hard to gather, but when you can, it's helpful. And then again, if symptoms are occurring during periods of abstinence. And then we wait and see what happens as we treat people too. So are their symptoms resolving with psychiatric treatment? So this is a pretty wordy slide, but I'm not going to read through it all, but this is looking at, again, differentiating the clinical characteristics between that independent psychiatric illness and a substance-induced one on the right. And so you can see again, there's the time component, there's the amount and the association of symptoms related to that amount. Are the symptoms going on during abstinence? And then the other aspects of history, including family history. Okay, so the next few slides are a lot of red and blue, and the basic thing breaking down to look at here is for each of these substances on each slide, you'll see an intoxication section on the top and a withdrawal. And the point that's being made in these slides is namely that you can see what's in red from both the intoxication or withdrawal from the substance and the psychiatric, perhaps the psychiatric comorbidity, whatever that may be. However, the ones in blue, you're not going to see from their psychiatric illness. These would be things that would indicate substance intoxication alone or withdrawal state alone. So important too in terms of determining effective treatment, especially in these acute states. So for alcohol, for instance, we're going to see in the intoxication state and potentially in psychiatric illness, the mood lability, impaired functioning, impaired judgment, but the slurred speech and steady gait, impaired memory, I think we could say maybe a red one, or put it in purple, stupor, coma, those things are going to be just from the substance alone. And same in the withdrawal state, these are the things that you'll be looking for. I'm going to move along here without reading them all. Here where this slide is focusing on our stimulants, so cocaine or amphetamine. You can see here commonly, things that may come up of increased anxiety, perhaps hallucinations, agitation. These may also be things that we see in psychiatric illness alone or from the acute intoxication. But if you're seeing things like sweating, cardiac symptoms, certainly seizures, etc., these are things that would not be from the psychiatric comorbid state. And there's your withdrawal that could overlap with both. For cannabis, here again in the intoxication state, you'll notice the ones in red that are combined and in blue from the substance alone. And then in the withdrawal state, certainly we may see with depressed mood, irritability, anxiety. We may see that in a lot of cases of psychiatric illness as well. Strange dreams might too, but in this blue section, sweating, nausea, obviously the physical symptoms we'd see in the withdrawal state alone. For opioids, again, an intoxication state, we may see that psychomotor retardation, euphoria, agitation, and that may be from the substance as well as the psychiatric illness, versus here are the signs that we would see in blue from the opioid intoxication alone, and also in the withdrawal state. And this is going to come into play importantly, like in your COWS scale, for instance, if you're using that to help determine certainly an inpatient setting, and also maybe when you're guiding someone in their outpatient setting for starting buprenorphine, for instance, kind of distinguishing these things can be helpful in terms of if they're experiencing withdrawal from the opioid, for instance. If it's at the point of anxiety alone, you would probably want to counsel them to wait a little longer till they're experiencing some of these physical symptoms, because then you know that you've moved into really the physical effects of the opioids. And then nicotine, we mainly just have the withdrawal state here. So again, a lot of those you could see with co-occurring psychiatric illness, but bradycardia, you would just see that medical sign from the withdrawal of nicotine. Okay, so that was kind of our broad strokes look at things to consider in those states of intoxication or withdrawal. Now moving into treatment considerations, this is what I was talking about, that we definitely want to try our best to treat both concurrently. So I think this is sort of a drastic picture of, and I'm not sure what this guy's doing, but of the ship going down if we don't help both holes in it. But so for substance-induced and dual diagnosis, previously it was thought that we would, wait for 6 months that people were completely off the substance and then treat. And that was really a huge barrier for many people until relatively recently, I would say. And then the sort of general take was to wait about a month before treating. Really, dual diagnosis should be treated simultaneously and not in sequence. I would say once you get past that initial very acute acute stage of withdrawal or intoxication, where again, you can't even maybe gather the information that you need to treat appropriately. But all of this should transpire relatively in a simultaneous pattern, not having to wait a whole month. And it'll hopefully increase their chances of retention and treatment as well. So also important to remember when considering treatment that substance use does not equal substance use disorder. We really want to make sure that we've evaluated, as with the psychiatric illness, make sure that patients are meeting criteria, even if only 2, but at least 2 out of 11 of those criteria from the DSM-5 to ensure appropriate treatment. Oftentimes we'll get referrals, from let's say from the emergency room because someone tested positive once, but then they come to us for treatment and they actually don't have a use disorder. And so they're not really matched to appropriate treatment. So we do want to make sure we're adequately assessing and diagnosing. Steps to treatment, really psychotherapy, if hoping for access to that. It should be the first line treatment in patients with substance use disorder and less severe depression or anxiety. And pharmacotherapy would be step 2, again, waiting until they're not in the intoxicated state, just to make sure you're able to do an adequate assessment. But it really should be first line, certainly in cases of more severe symptoms, and then hopefully with the support still of psychotherapy. So in general, some common things to keep in mind that depression and anxiety are very common at treatment entry, especially specific for substance use treatment. And these symptoms may resolve within a few days that they've been on treatment and through the intoxication or withdrawal state. But if something persists beyond that acute stage, really they would be worthwhile to consider treatment. And we'll look at the next slide, or in a couple slides, the next slide, some of those options. But one example is our first line would be our serotonin reuptake inhibitors, or SSRIs. And importantly, patients who are treated with medication for opioid use disorder respond to medications for depression and anxiety at rates similar to those without opioid use disorder. So another reason not to withhold these medications. This has been looked at in terms of rates of response to treatment. We want to be offering them broadly, not withholding those medications. We do want to try to avoid addictive medications if possible, which we would in the general population as well. But as referenced earlier, there's that increased risk of a concurrent or subsequent substance use disorder in someone who has one or more. And so want to really take care there and then monitor carefully. Here are some of the what would be considered first line for this isn't all inclusive for sure, but some examples of medication recommendations in the primary care setting. Again, for our depression, anxiety, considering the SSRIs, SNRIs, depression may also might consider bupropion as well. And then certainly for PTSD, we also, while the evidence is very strong for the therapies that are specific for PTSD, there are some medications that can be helpful as well that we would like to offer at the outset. Again, those SSRIs, prazosin has some treatment effect in certain cases as well. And he's listed valproate here for bipolar disorder. That's certainly one that would be safe in most cases in our patients with co-occurring substance use. And just in the last couple of slides, this is just looking at the receipt of substance use treatment or mental health treatment among adults in the past year. This is the data from 2022. And you can see of this whole pie of 21.5 million adults who have substance use disorder and any mental illness, that almost a very large portion of the pie, so 40% received no treatment in the last year. And then a small slice up here, about 4% received substance use treatment, but no mental health treatment. Here's our slice that has 17% of both substance use treatment and mental health treatment, so hoping to expand this. And here we have mental health treatment, but no substance use treatment. So We have work to do, and you all are doing that work, which we're grateful for. And then this diagram is looking again at adults with substance use disorder and a serious mental illness. So here, the no treatment portion of the pie has gone down slightly to about 30%, still a pretty small slice, at just over 2% of substance use treatment, but no mental health. And then this part here at about 24% who are receiving both substance use and mental health for serious mental health treatment. So this is our last slide. This is just showing you the integrated approach that's recommended by SAMHSA to treat co-occurring mental and substance use disorder. Really calls for collaboration across disciplines. I think what we're doing here is one example of how that can work. And so grateful that you all are doing this work together. And it really is client-centered and focuses on the patient's goals, which might not be complete abstinence, and that's okay if we're helping them reduce their risk. Then we are doing the work. The integrated treatment is associated with lower costs and better outcomes, which include reduced substance use, improvement of psychiatric symptoms and functioning, decreased hospitalization, increased housing stability, fewer arrests, and improved quality of life. And these other models of treatment tend to be sequential and parallel, but this one is one that's really integrated and is incorporating all of these elements that are going to increase someone's chances of meeting their goals.